Hello, everyone. My name is Solomay Tibabu. I'm the host of the Going Digital Behavioral Health Tech Conference. I'm so excited to have DynamiCare here with us, along with Vermont Medicaid team. Super excited for this session. Why don't we start off with a couple introductions? Eric, how about you go first and share more about DynamiCare?
Thanks, Salome. I'm Eric Gastfriend. I'm the CEO and co-founder of DynamiCare Health. We are a digital health company focused on helping people overcome substance use and addiction. We work across drugs, alcohol, and even tobacco. And we have a digital care program that combines supportive recovery coaching with an award-winning app and substance testing equipment for remote tests and financial rewards for staying sober, staying engaged in treatment. We're very excited to present today.
Hi, I'm Christine Ryan. I'm the Nursing Operations Director at Vermont Medicaid, and I'm happy to be participating in this effort with DynamiCare.
And I'm Scott Strenio, family physician, and I'm the Chief Medical Officer for Vermont Medicaid.
Wonderful. So let's start with Eric. Where should we begin with the problems in addiction treatment?
Well, there are a lot for sure. I would begin with the overall numbers. So in the US, we have 20 million Americans who meet the clinical criteria for a drug or alcohol addiction, according to DSM-5 criteria. And only around 2 million Americans get treatment on an annual basis for drug or alcohol addiction, which means close to 90% of people who meet the clinical criteria are not getting treatment. And sometimes it's because they don't think they have a problem. Sometimes it's because they don't want treatment. Often the treatment system that we have is not enticing or attractive to people. It can be stigmatizing, can be inconvenient, can be expensive. It can force people into a certain mindset or philosophy around addiction treatment or abstinence that they may not agree with. So I think we need to start asking the question and working on the problem of not just how do we have something available for the people who really, really want it, but how do we get more people engaged and involved in treatment, make it more accessible so that we don't have the situation where only around 10% of people who need treatment are getting it.
Right. And Vermont Medicaid team, how did you learn about DynamiCare?
So we work closely with our colleagues in the health department who have a team dedicated for smoking cessation that's been there quite a while. And we always supply a lot of data to their efforts. We became aware of a program that DynamiCare was working with them and also our researchers at the university around smoking and pregnancy. And quite honestly, I think that Christine and I have been interested in not just the mobile technology, but also the use of incentives for quite some time. And so we got to know Eric and his father, and that was all she wrote.
And I'll add, my father, Dr. David Gastfriend, is an international expert in addiction psychiatry, my co-founder and chief medical officer. So he's been involved from the very beginning and now too.
So Eric, what exactly are you doing in Vermont with DynamiCare Health?
Yeah, so we are partnering with Vermont Medicaid on a large research study to try out DynamiCare for alcohol use disorder across the Vermont Medicaid population. We're now enrolling 300 Vermont Medicaid members to provide them with the full digital care program that DynamiCare offers, specifically for alcohol use disorder, although people could have other issues too. And with that problem we mentioned at the beginning of most people not getting treatment, with DynamiCare, we designed the program in a way to make it more enticing to engage people, not having it be scary or inconvenient or stigmatizing. So it's a digital rewards-based coaching program. It's on your phone. You get a coach who supports you in achieving your goals, whether that's full abstinence or more moderation goal. And you do breath tests and saliva tests through the app at random times. And every time you pass a test, negative breathalyzer or negative saliva tests for different drugs, you earn rewards on a smart debit card, which blocks access to bars, liquor stores, and cash withdrawals. And it's a safe way of providing funds, but it's also very effective because it's immediate, and it creates a gamification loop around positive behaviors leading to positive rewards. And instead of punishing people for doing the wrong thing, we're rewarding them for doing the right thing in their recovery. So we're working with addiction treatment programs where they can refer people to this program after they finish detox or rehab or as they're starting outpatient. But we're also seeing success in doing direct-to-consumer Facebook ads, getting people into this program who might not otherwise even be seeking treatment. I think that's really exciting. And in terms of the research goals, of course, we're looking at the clinical impact of DynamiCare in terms of drinking and substance use. But one of the really great things about having this partnership with Vermont Medicaid is we'll also be able to look at claims data to see the ROI impact that this has. And I think that will be a very powerful information and knowledge to have, because we know that substance abuse is a huge driver of costs, but we don't have much proof yet or knowledge yet around which interventions can actually reduce those costs. So we're excited to be working on that with Vermont Medicaid.
Excellent. And Dr. Strenio and Christine, can you share more about what are actually some of the addiction challenges throughout Vermont, specifically around drug, alcohol, tobacco issues? And why do you choose DynamiCare to support?
Well, in terms of why we chose DynamiCare to support, first of all, it's free, it's confidential, and it's very convenient and for individuals to engage with, especially given what we know and have recently experienced with the public health emergency. Individuals are looking to engage differently with different treatment modalities. So the timing actually couldn't be better. The other piece of that is DynamiCare is, as Eric mentioned, is able to encompass, a wide spectrum. It isn't just alcohol, right? We know that there are other treatment specialty areas there that could also be expanded upon, which, Vermont has an opioid crisis as well. For example, so there's the possibility to expand the uses of incentives beyond just alcohol.
And I think, thank you, Christine. I think the other thing is, Vermont's governor a number of years ago sort of made the headlines talking about the opioid epidemic, and even in a state like Vermont that made national news, that he addressed that as a #1 priority. And we developed a hub and spoke system specifically to be able to deliver medication treatment. So there's been a lot of focus on the opioid crisis. But at the same time, alcohol use disorder is actually more prevalent than the opioid issue. And so trying to address that is something that was very, very important, and it was not widely addressed. I mean, it was always known that there's a lot of alcohol use disorder in Vermont, but it sort of took a second class setting because of the focus on the opioid problem. And we are a very rural state, so that for people to seek care is a challenge to begin with. And then you throw in the public health emergency, and now you really have not only people suffering with additional stress in their lives and maybe turning to a variety of things to try to mitigate that stress, but then you also have access is a huge issue for our population. So I think all those factors made Vermont a really an ideal place to work with Eric's team.
Wow, yes. Sounds like really an opportunity to bring in some new interventions for some of the issues you've outlined. Can you talk about practically how you're rolling it out?
So we partner with again another team at the health department, our alcohol and drug abuse program, ADAP, and they're the ones that actually oversee the hub system in Vermont. But of course, they focus on much more than just that. And we've tried to explore every opportunity for people to enroll, to get to know the program, what it's about, what it can do, the success that it's had in the past, and help facilitate our Medicaid population to enroll, and putting DynamiCare in touch with a wide variety of providers across the state.
Yeah, and so we've started out working with different providers in the state, and we've kind of branched out from there, including doing flyers and Facebook ads to try to reach the population that's not currently in treatment. And obviously we're a little bit limited during COVID, but now that the vaccine is out, we're hiring an engagement manager to go around in person to the community centers and treatment programs to enroll members into the study, which we're really excited about. One other thing I wanted to mention is this work with Vermont Medicaid and this study. It's actually phase 2 of another pilot study we did. Where this is going to be a fairly large study with 300 members. We did a pilot in Massachusetts with 60 patients in an outpatient alcohol use disorder clinic, where we saw a doubling of quit rates or negative urine tests from alcohol. So based on the success of that kind of pilot program, we're now working on rolling it out more at scale with Vermont Medicaid as our partner.
Now, a little more on that, Eric, if we can. This is not easy. Why work in Medicaid, given how many barriers exist for digital health and innovation?
Well, there are certainly a lot of barriers, but Medicaid is a really important payer for the healthcare system in general and for substance use disorder in particular. According to the national data, 21% of national spending on addiction treatment, which is about $40 billion annually, is paid for through state level Medicaid programs like Vermont's. And also thinking from an equity perspective, Medicaid is usually the payer that's covering the neediest population and some of the people who need DynamiCare the most, who might have the fewest options for convenient digital or telehealth tools. So it's really exciting for us to be able to work with this population and work with the state Medicaid program. We're seeing interest from other state Medicaid programs too. Actually, there is a new policy priorities document from the White House Office of the National Drug Control Policy Office. It's also called the Drug Czar's Office. And they have announced some of their priorities are going to be digital treatment for addiction and also motivational incentives for addiction treatment, which DynamiCare does. And part of the reason for that is, in addition to the opioid epidemic, which I think everyone is pretty familiar with, there's also a new stimulant epidemic, meth and cocaine. And there are no FDA-approved medications to treat meth and cocaine addiction. The most effective and evidence-based intervention we have is using a motivational incentives approach, which DynamiCare automates. And that's why we were the subject of a New York Times article that came out at the end of last year about this issue. And that's why the Biden's drug czar's office is prioritizing this, and we're seeing interest from other Medicaid states too, because Medicaid is really at the front lines of fighting our substance use disorder epidemics. And in terms of the barriers, I think every state Medicaid program is different and works differently. Vermont's is a bit unique in that it's a fee-for-service system that doesn't go through Medicaid managed care organizations. So the government agency that Dr. Strenio and Christine work for, they're directly managing the Medicaid program themselves. Other states, they contract to managed care organizations that, like large healthcare organizations, usually for-profit companies that manage the care. And then that becomes even more complicated because then you have to be contracting at multiple levels with multiple stakeholders. So it's definitely an interesting challenge, but we're actually seeing a lot of interest, not just for DynamiCare, but in substance use disorder generally and digital health generally among the Medicaid managed care organizations and states.
I think there's been a concerted effort to do cross-pollination or more collaborative efforts. You know, I know state Medicaid agencies have always communicated, and there is a network, and, you know, trying to engage in innovative approaches around substance use disorder, you know, is an area that I think the state leadership is becoming more aware of. You know, it's always, I believe, been on the radar, but more so now, and trying to engage and share information around in approaches that have worked or that are going to be piloted, trying to learn from each other in a way that is really beneficial, and knowing that there isn't, you know, one particular approach that's going to solve all of it, that it takes you know, it takes a variety of approaches to do that, and using motivational incentives is one way to do that. And like Eric said, you know, there's a lot of potential in other areas that currently there isn't some real you know, clinical evidence-based approaches to. So I think the ongoing discourse, dialogue, collaboration around the use of motivational incentives has risen to a state level, and as Eric mentioned, is clearly you know, at a national level as well.
And if I can add to that, I think Christine touched on a very important point about the you know, trying to deliver the care to where the people are, and not making them go someplace for it. And we've seen, you know, in other states where the use of incentives is very effective. It's very effective. But Medicaid doesn't have a bank that it can just draw down money to do different kinds of pilots. We have a fee schedule. We have to think about how to pay for a service that is rendered. The thing that is very exciting about doing this, I think from our perspective, is also to show that incentives, in fact, not only clinically provide better outcomes, but also can be very cost effective. So that every dollar that you spend in using some kind of reward-based system may save you many multiples of that in terms of avoidable utilization of emergency rooms, hospitalizations, let alone just from a financial standpoint, but also just, you know, the human cost in families and children, parents, relatives. The thing that we are also doing is working closely with our Department of Corrections, and to be able to tie in what we do on the Medicaid side of the street with people coming out of corrections, most of whom end up on Medicaid, and there is no shortage of substance use disorder in that population. To be able to have that connection would be extremely powerful. And the thing that might be interesting to people to remember, that Medicaid expenditures are they're largely federal dollars that go into the Medicaid program. Maybe 2/3 of the cost is from CMS, but states correctional costs are 100% state dollars. There is no supplemental funding from the federal government. So every time we can do something to save dollars spent on correctional costs is a big deal. So I think that's another really interesting connection here, to be able to pilot with a program that delivers access using remote devices, that is reward-based. To be able to show that means that we can actually start thinking about using incentives in other ways as well, not just in substance use disorder, which is obviously extremely important, but also for people to get the care that they need, whether it's what we call closing gaps in care, the screening tests that should be done. There are managed care organizations in the country that reimburse patients for getting their colonoscopy, their mammogram. So to some degree, the ability to use this pilot, this program, and to show how effective that can be has, I think, really large implications for the future.
Can you talk a little bit about what the reimbursement landscape is for tools like this?
It's a challenge. It really is a challenge, because again, Medicaid pays for services based on claims on a service that is rendered. So unlike our health department and many other projects that are funded through grants, they can get a program up and running and they can demonstrate efficacy. But for Medicaid to take this on as a service that we provide, it's a matter of being able to bill for the services, and that's a challenge. Eric knows that, and Christine, and we've been working on ways of trying to do that. And Eric, you may have more up-to-date information on that that you might want to share.
Yeah, I mean, I think if we can, in terms of working with Medicaid, and I think this applies to payers more broadly too. Broadly speaking, there's the admin budget, and then there's the medical loss or medical expense budget. And you definitely want to fit it into the medical expense budget rather than the admin budget across the board. And then within the medical expense budget, you have claims, which are the biggest category, and those are usually tied to billing codes. Then you also have some things like case management that DynamiCare or other digital health services can fit under. That case management doesn't necessarily have to be tied to particular codes. And then within, I think using codes is the best option for now for digital health companies. If they have a service component, you can't really use codes without a service component unless you're like a medical device and you can be part of a formulary. I think the digital health formularies are really exciting that CVS and Evernorth have. That's more on the employer side. There are some CPT codes that digital health companies can use. In the case of DynamiCare, because we do recovery coaching, there's a code H0038 that applies to the work that we do. There are also remote patient monitoring codes that could be relevant. And I think the American Medical Association and CMS are working on creating some new codes to make it a bit easier for digital health companies to work through the coding system. But generally the coding system is built around clinicians' time and not around value or technology. So it is a challenge to try to fit it in. In terms of other options like bundled rate or PMPM or value-based contracts, I think all of those are promising and exciting, but I find for a lot of health plans, especially in Medicaid, it can be very challenging to work through the details of those types of contracts. So if there's a way to kind of structure codes around it, and a bundled rate, I think is easier than trying some of the more complex contracts like a value-based contract. So, you know, that's, I think, something that every digital health company is working and struggling with, but making progress on.
Right. Thanks so much, Eric, for pointing that out, because I do think many cutting edge providers and innovators, digital health companies are grappling with that actively. Can I ask, how has the pandemic impacted things from the care delivery to the deployment of innovative tools? And do you think some of the digital stuff will stick?
Well, I think we've seen a significant increase in the use of telehealth, right? Telemedicine. And I think what we knew medicine, the delivery of healthcare, and the payment of healthcare, it's going to be significantly different. We're not going back to the way it was. There is a new landscape in front of us. And so I think in terms of Vermont, we saw rapid adoption, and I'd say within the Medicaid population that, there was, use of telemedicine for sure during the pandemic in ways that was incredibly beneficial, both from the consumer adoption as well as the provider. And our job going forward is going to be thinking about what have we learned from that, what's worked well, what hasn't, what needs to be refined, but it's here. And so, engaging and utilizing newer technologies that are going to support the specific population and the disease, as well as create the clinical outcomes, is really where we want to be targeting.
That's exactly right. That through the pandemic, one of the positives is the adoption so readily of telemedicine and telehealth, which this fits the bill exactly. And there's sometimes a misconception that the Medicaid population doesn't use smartphones as much as anyone else. And actually, in my experience in other health plans in the country, the adoption of smartphones is something that the Medicaid population actually takes up pretty quickly and uses that to their benefit. Again, the accessibility is huge because transportation, just as a little side note, is a huge problem for many people in Medicaid. A lot of times there's no car, or there's only one car that doesn't get home until night. There can be sporadic public transportation, especially in a rural state. So, and as a matter of fact, one of the biggest things I think that the Medicaid program offers in most states is a transportation benefit, but it's often stretched to its very limit. And so it's not a surprise to me that many people in Medicaid turn to smartphones for a whole lot of things, and being able to get them comfortable with using telemedicine as a whole, I think allows for this project with DynamiCare to accelerate.
What are you excited about in terms of the future of substance use care?
I'm excited about the whole ecosystem that's developing around substance use disorder. DynamiCare is a great solution and a great offering, but we're not claiming to be the solution to addiction. We're hopefully one solution among many. And, we target a certain I would say, severity or acuity index along the care continuum. But we need to have new forms of detox, of residential, of intensive outpatient. We need to have new channels of getting people into treatment. We really need a better front door to treatment because people are Googling treatment options and then getting led to whichever one is bidding the highest on the keywords. So it's really hard for people to find the right kind of treatment for them. And then also it's very much kind of like a system where we wait for people to come to the treatment system. But we have to be a little bit more proactive in terms of reaching the people who need treatment or services, but aren't ready to reach out. And that's something we're trying to do with the Facebook ads, but there's a lot more ways that can be done. So I really love to see an ecosystem of digital health built out around this disease and then linked to related issues like depression and anxiety, other areas of mental and behavioral health. And then I think we can start to do a much better job of managing this disease.
We've got an audience here of other payers, providers, investors, digital health entrepreneurs and innovators, policy folks. What can our audience do to help move forward initiatives like the one we're talking about here?
I think there's a lot that anyone can do. I think first, being aware of what are the digital health solutions that are out there for a particular, any particular disease area or target population is great, because even if you don't have the opportunity to implement it within your organization, if you can let people know about that and spread the word. I think oftentimes clinicians and providers want to adopt technology, but it's hard for them because they don't control the checkbook and what gets covered or not covered under health and benefits. But I think providers can have a lot of sway and influence if a digital health company like mine goes with a clinician or provider to a payer or health plan to present an idea for trying something out or piloting or getting something covered. It's a lot better than if I just approach the health plan myself to have that kind of backing. I think health plans are looking at a lot of different solutions and it may feel inundated, but there's a lot of good stuff out there. I think the important thing is to look at the research on what are the actual validated outcomes, and for the health plans to connect with each other too about what solutions are working.
I'd say to continue to look for areas of alignment and to be able to expand on that, to continue to investigate and to understand the clinical presentations of the population and the challenges that are happening, and to recognize that technology offers some fantastic possibilities and the innovations, and to try these things and to learn from that data and that experience as a guide to move forward.
It's interesting because when we look at things that we want to do in Vermont, we often want to find what another state that is similar in size and geography to us and see what data they have. But the best data that any will convince a state is their own data. So the fact that DynamiCare was already working in Vermont with the smoking and pregnancy issue really made it a lot easier to be convinced of its effectiveness. And I will tell you, I belong to a network of Medicaid medical directors across the country, and everyone is looking for new and innovative things that can be done. And again, the fact that telemedicine is here to stay and is clearly been implemented across the country means that you don't have to build so much of the infrastructure to take on something like what DynamiCare offers. So that it's really a perfect time to be able to show its effectiveness. And the fact that this problem is not going away. And whether it's any kind of substance use disorder, it's an issue that I think what DynamiCare brings to the table is just an excellent solution. And within a state, I just want to add that word of mouth is the best way to promote any kind of innovative technology, right? I mean, and I think that that's clearly what's happening, not just word of mouth among the patient population, but also among the providers. When because doctors, nurses, you name it, they really want to be able to provide that care that helps their patients. Even being able to offer whatever you can offer because you had a visit to the emergency room, right? You strike when the iron's hot, and when the problem has really caused the most distress is when you often get the biggest response from the population.
This has been tremendously insightful. I only wish we had more time. Thank you so much, Christine and Dr. Strenio from the Vermont Medicaid team, Eric from sharing all of the great work you're doing with DynamiCare Health and hearing about this partnership. Really exciting, and thanks so much for joining us.
Thank you.
Thanks so much.